My name is Brian Horwich. I'm a gastroenterology fellow at the Mount Sinai Hospital.
And I'm Emily Leven. I'm also a gastroenterology fellow at the Mount Sinai Hospital. We're here today to talk about the evolving paradigm of alcoholic hepatitis and liver transplantation. So to get started, we're just going to review the current medical treatments of alcoholic hepatitis and their limitations. Really, the mainstay is still supportive care of all of the coexisting issues that come with alcoholic hepatitis. Many of these patients end up very sick with multi-organ failure. If patients do make it out of the initial hospitalization, abstinence from alcohol is incredibly important in maintaining health going forward. For those patients who are able to tolerate steroids, steroids are really the main medication that is available for treating alcoholic hepatitis. There are a few other therapies which have had smaller trials studying their effect. NAC, GCSF, and FMT are really the three big ones that have also been studied.
So because the medical therapies available are quite limited in the treatment of alcoholic hepatitis, there's been a lot of interest and exploration for liver transplantation and treatment. The current treatment paradigm for alcoholic hepatitis and specifically severe ALCHEP is as follows. First, an individual is evaluated as to whether or not they'd be a candidate for glucocorticoid therapy. If they are, they're subsequently treated, and that treatment is the response to the treatment is evaluated using the Lille score. If someone is a steroid responder, their estimated 6-month survival is about 63%, versus those that are steroid non-responders, that estimated 6 months survival drops to 25%. If someone's not a glucocorticoid candidate, the next step is then evaluating as to whether or not they would be a candidate for liver transplantation. If they're not a candidate, their 6-month survival is comparable to that of steroid non-responders at 38%, versus if someone is a liver transplant candidate and successfully undergoes the transplantation, their estimated 6-month survival skyrockets to 88%. So because liver transplantation has been so beneficial for these patients, it has become a much more commonly sought out treatment. The use of liver transplantation for treatment for ALCHEP can be broadly divided into sort of two large categories. The first being individuals that are able to remain abstinent for 6 months prior to transplantation versus those who receive transplantation prior to that 6-month period and carefully selected patients because the mortality within 6 months is so high. However, because of the role of alcohol in the pathogenesis of the disease, there are a number of challenges associated with early liver transplantation for alcoholic hepatitis, specifically as it relates to the ability to maintain abstinence from alcohol use after transplant. So one of the major challenges is dealing with both the social and healthcare system stigmas associated with alcoholic hepatitis, with implicit biases of the patients being at fault for their disease, and then also using standardized assessment tools like the Stanford Integrated Psychosocial Assessment Tool for transplant to more objectively evaluate these individuals. And a very important part is the evaluation of recidivism risk, or the risk of them going back to drinking after transplantation. So there are some objective prognostication metrics that have been developed, like the sustained alcohol use after liver transplantation, or SALT score, and then also having more formalized assessments of patient insight into the role of alcohol in their disease process prior to transplantation. And finally, post-transplantation support is an enormous challenge and also a need for these patients, providing structured rehabilitation programs, and also having a consistent evaluation and management of comorbid conditions that contribute to alcohol use, like other concomitant substance use disorders or psychiatric conditions. We'd like to thank our mentors for this project, Drs. Adam Winters and Kamron Pourmand at the Mount Sinai Hospital, and also I'd like to thank Clinical Liver Diseases for giving us the opportunity to talk about this topic.